After intubation, pinning and shaving, local is injected. The MRI checklist is reviewed, as is the surgical table. The patient's gurney is moved into the scanner and moved to the surgical position at the back of the bore, where the area is prepped and draped. A drape allowing for free movement of the patient from the surgical position to isocenter is placed. A set of elastic bands is passed to the far end of the bore, followed by a set attached at the surgical end. A marking grid is placed in the region of the expected entry site, and the patient is moved to the magnet isocenter for a contrast-enhanced volumetric scan. Entry point and trajectory planning are performed at this time. The skull is marked with a sharp marking tool at the chosen grid position.
So when you place that grid,
The incision is marked and opened with a surgical blade. Periosteum is bluntly dissected, and hemostasis is achieved with bipolar cautery. After a retractor is positioned, a borehole is created with a cutting drill. The edges of the borehole are bone waxed. The size of the borehole is checked using a centering tool. The dura is coagulated and opened, and the smart frame base is secured into the outer table of the skull. The smart frame tower is attached, together with a hand controller, and the patient is moved to isocenter for lead placement. The targeting scans allow for adjustment of trajectory to assure accurate placement. As shown here, the pitch and roll trajectory adjustments are made first.
Roll orange 7/8 to the right.
The XY adjustments are made last to fine-tune the trajectory. The depth of placement is verified by the software. A ceramic stylet is slowly advanced to target, with interval scans verifying proper trajectory. Once at-target scans are complete, the DBS lead is opened and inserted. The patient is moved to the back of the bore for the removal of the smart frame components and the securing of the lead. After the Stimlock cap is placed, the wound is copiously irrigated and closed with sutures and staples.